What's up everybody? In today's video we are going to talk about organophosphate poisoning, its presentation, how to manage it in the emergency department. So organophosphate poisoning, also known as insecticide. So look at what is the presentation of organophosphate poisoning, how do you manage it in the emergency department. First of all, organophosphate are commonly present as insecticide and they are more common in developing countries. Other than that, organophosphate nerve gas agents like sarin, these organophosphate agents, they can be absorbed through the skin, gut, bronchial mucosa, and they can accumulate in the neuromuscular junction. So let's talk about the mechanism of action of organophosphate poisoning. So in the mechanism of action of organophosphate poisoning, we've got the presynaptic neurons and the postsynaptic neurons. The presynaptic neurons releases acetylcholine, and this acetylcholine binds to the receptors present on the postsynaptic neurons. And this acetylcholine causes the stimulation of the receptors, resulting in increased parasympathetic activity. Now, this acetylcholine is then degraded by an enzyme, acetylcholinesterase, therefore to prevent overstimulation of postsynaptic neurons and the receptors. So what organophosphate does is that they block this enzyme, the acetylcholinesterase. Initially, organophosphate reversibly blocks or bind acetylcholinesterase, and then after a few hours have passed, aging starts taking place, and the binding of organophosphate to the enzyme becomes irreversible. You cannot reverse it. Inhibition of the enzyme results in the accumulation of acetylcholine in the neuromuscular junction. Accumulation of acetylcholine in the neuromuscular junction result in overstimulation and increased parasympathetic activity. So let's talk about the presentation of organophosphate poisoning. So presentation of the patient will be that the patient will be having all the signs and symptoms of increased parasympathetic stimulation. The signs and symptoms, you can easily remember them with a mnemonic that I've come up with, which is dumbbells. D stands for diarrhea, U stands for urination, M meiosis, B bradycardia, E emesis or vomiting, L lacrimation, L another L for lethargy, S for salivation. So in severe cases of organophosphate, what you would see is that the patient will also have bronchospasm. The patient will also have increased bronchial secretion. So these are all actions of parasympathetic nervous system, and in few severe cases you might be able to see convulsion and coma. Hypoglycemia and cardiac arrhythmias are also seen in severe cases of organophosphate poisoning. So symptoms of organophosphate poisoning can be delayed. So delayed effects are seen after 1 to 4 days of organophosphate poisoning, as cranial nerve palsies, muscle weakness, respiratory failure. And sometimes after 2 weeks, the patient might present to you with peripheral neuropathy in the legs, which makes the diagnosis difficult. So let's talk about the management of organophosphate. First of all, as I said earlier, that organophosphate can easily get absorbed through the skin, so you must ensure that all the staff wears protective clothing like mask, gloves, and proper protective equipment. So then you should also remove all the clothing of the patient and then change them with the hospital clothing to reduce absorption of poisoning. So you also have to do the ABCDE approach. You should clear the airway secretion, you should do the suction, and you should give oxygen, and in some cases intervention positive pressure is indicated. You should insert the IV cannula, and you should maintain the venous access. Then you have to take the blood samples for cholinesterase levels. Remember that the blood sample of cholinesterase is taken in the EDT tube on ice, and so you put the EDT air tube in ice while you shift it to the laboratory, because you have to maintain the temperature of 4 degrees Celsius, otherwise the result will be wrong. If the patient is convulsing and they're having seizures, you can give diazepam to treat agitation and convulsion if the patient is having seizures. So if there are profuse bronchial secretion or bronchospasm, in that case you have to give atropine. So in adult, atropine you give 2 mg, and in children, atropine you can give 0.02 mg per kg, and then repeat it every 5 minutes with dose doubled every 5 minutes until the chest is clear, systolic blood pressure is greater than 80, and the pulse is greater than 80. In moderate to severe cases, you should give pralidoxin. Now remember, as I said, that initially organophosphate irreversibly blocks or bind the acetylcholinesterase, and then after some hours have passed, aging starts taking place, and the binding of organophosphate to the enzyme becomes irreversible. You cannot reverse it. Now, if you give pralidoxin within 24 hours of exposure, when the binding is reversible, then pralidoxin will effectively detach the organophosphate from the acetylcholinesterase, and the enzyme will be free. But after 24 hours, if you give pralidoxin, it will be ineffective because the organophosphate will have irreversibly bound the enzyme, and pralidoxin will not be able to detach it. So the dose is 30 mg per kg IV over 30 minutes, then followed by IV infusion at 8 mg per kg per hour. So improvement is apparent within 30 minutes. Thank you for watching this video. I really hope you found this video helpful or useful. If you did, please don't forget to like this video, and please consider subscribing to the channel. Thank you very much. See you in the next video.